It starts quietly. You notice you haven't gone in a day or two, but that happens sometimes so you don't think much of it. By day 3, there's a heaviness low in your abdomen that wasn't there before. A pressure. Not quite pain, but something uncomfortable that you can't quite shake. You sit on the toilet, you push, nothing moves. You try again after breakfast, still nothing. Then on the 4th attempt, your body sends you a signal you cannot ignore, a sharp, grinding cramp deep in your pelvis. Your lower back begins to ache in a way that feels nothing like a pulled muscle. Your stomach looks swollen. You feel vaguely nauseated, slightly feverish, and somewhere in the back of your mind, a thought surfaces that genuinely frightens you. What if this isn't something that fixes itself? If any part of what I just described sounds like where you are right now, or where someone you love has been recently, I need you to stay with me for the next 20 minutes, because what I am about to walk you through could genuinely protect you from one of the most underestimated medical emergencies affecting Americans over the age of 55, one that hospitals see every single day, one that almost nobody talks about openly until it becomes critical. My name is Dr. Scott Franklin, and today we are going to have the honest, detailed conversation that most doctors simply do not have time for in a 15-minute office visit. We are talking about stool that becomes physically trapped and hardened inside your digestive tract. What causes it? How your body tries to warn you before things turn dangerous. The symptoms that confuse almost everyone, including some physicians. And exactly what you need to do about it, starting tonight if necessary. By the time we are finished, you are going to know your own body better than you ever have. And that knowledge may be the most important thing you hear all year. Let's get into it. Before I give you a single solution, I need you to understand the problem at a level that most people never reach. Because here is something I have learned after decades of treating patients. When you truly understand what is happening inside your body, you stop panicking, you stop making it worse, and you start making the right decisions. So let's go there together right now. First, I want you to drop a comment below and tell me where you are watching from today. Your city, your state, wherever you are. I genuinely read through these, and it matters to me who is in this community. All right, let's get into it. Most people think of constipation as simply not going to the bathroom. And that misunderstanding is exactly why so many people end up in serious trouble. What we are actually dealing with here is a mechanical and physiological process that has been building quietly for days, sometimes longer, and by the time it becomes painful, it is already significantly advanced. Here is what I want you to picture. Your large intestine is roughly 5 feet long. 5 feet of muscular tubing that winds through your abdominal cavity in a very specific pattern. Its primary job, the one task it performs above everything else, is to extract water from the waste material traveling through it. And it does this job extraordinarily well, almost too well in fact. When stool moves through your colon at a healthy pace, your body pulls just the right amount of moisture out, leaving waste that is soft enough to pass comfortably. But here is where things begin to go wrong. When that stool slows down, when it lingers inside the colon longer than it should, your body does not receive a signal to stop extracting water. It just keeps going. Hour after hour, day after day, that same efficient process continues pulling moisture out of material that has already lost most of its hydration. And the result is something that no longer resembles soft, manageable waste. It becomes dense, compacted, almost concrete-like in its consistency. Now here is the part that catches most people completely off guard, and I want you to really absorb this. This does not happen overnight, not even close. The progression from sluggish bowel function to a genuine impaction typically unfolds over 3, 4, sometimes 6 or 7 days. And during most of that window, you may feel only mildly uncomfortable. Maybe a little heavier than usual in your lower abdomen, slightly bloated, a little sluggish after meals, nothing that screams emergency. You might even still be going to the bathroom during this time. And this is where people get dangerously misled. Because going to the bathroom does not mean your body is eliminating what it needs to eliminate. In many cases, a small amount passes, a fraction of what is actually accumulating, and the rest stays behind, continues to dry out, continues to compact, and continues to build. Think of it this way. Imagine a slow-moving river during a drought. Water is still trickling through, but sediment is accumulating on the riverbed, getting heavier, harder, more dense with each passing day. Eventually, that sediment doesn't move at all, no matter how hard the current pushes. That is the mechanical reality of what is happening in your lower digestive tract right now. And the instinct most people have, to bear down harder, to push with more force, to strain through the discomfort, is exactly the wrong response. I want to be very clear about this because it is counterintuitive and critically important. Straining against a hardened mass does not dislodge it. What it actually does is compress it further, drive it deeper, and in some cases wedge it more firmly against the rectal wall. You are not pushing it out, you are packing it tighter. And every time you strain, you are also putting tremendous pressure on blood vessels and tissue that are already inflamed and irritated. Here is something else most people do not know, and this is particularly relevant if you are over the age of 55. Your digestive system does not age in isolation. It ages alongside every other system in your body, and several of those changes conspire together in a way that makes this exact scenario far more likely than it was 20 years ago. Your intestinal muscles, the ones responsible for those rhythmic contractions that push waste forward, naturally lose strength and coordination with age. The nerve signals that communicate urgency from your gut to your brain become slower and less reliable. Your thirst mechanism, the internal alarm that tells your brain your body needs water, genuinely weakens as you get older. You can be significantly dehydrated at a cellular level and feel no thirst whatsoever. And on top of all of that, many Americans over 55 are managing multiple health conditions and taking multiple medications, several of which have a direct and measurable effect on how quickly or how slowly your intestines move. This is not a personal failure. It is not a sign that your body is broken or that you have done something wrong. It is a predictable, documented consequence of biological aging that nobody sat down and explained to you until right now. But here is what I really need you to understand before we move forward. Understanding the mechanism is not just an academic exercise, it is the foundation of everything else we are going to cover today. Because once you understand why this happens, the solutions stop feeling arbitrary and start making complete sense, and that clarity is what is going to make the difference. Stay with me, because what comes next is where this gets genuinely important. I want to take a moment right here and ask you something directly. Have you ever experienced a symptom, something uncomfortable or unusual, dismissed it as unrelated to your digestion, and moved on without giving it another thought? Because if you answered yes, you are in very good company. And you may also have unknowingly ignored one of the clearest warning signals your body knows how to send. This section may be the most practically valuable thing I share with you today, because the symptoms of a developing or established impaction are genuinely misleading. They disguise themselves as other problems. They send you chasing the wrong diagnosis. And in doing so, they buy time for a situation that only becomes harder to resolve the longer it goes unaddressed. If what I'm sharing is new information for you, take a second right now and type the word yes in the comments. I want to know how many of you were never told any of this before. Let's start with the one that sends more people in the wrong direction than anything else. Watery, liquid discharge from the bowel. I know, if you are experiencing that, your first thought is almost certainly not constipation. Your first thought is that you have a stomach virus, a food poisoning episode, or some kind of intestinal infection. And that instinct is completely understandable. It is also potentially dangerous. Here's what is actually happening. When a large hardened mass of stool becomes fully lodged in the lower rectum, it creates a near-complete blockage. But the digestive system above that blockage does not stop working. Newer, looser material continues to travel downward from higher up in the colon, and when it reaches that solid obstruction, it cannot pass through, so it does the only thing physically possible. It seeps around the outside edges of that hardened mass and escapes as thin, watery liquid. This is called overflow diarrhea. It is a recognized clinical phenomenon, and it is one of the most consistently misunderstood symptoms in gastrointestinal medicine. The critical danger is this: people experiencing overflow diarrhea frequently reach for anti-diarrheal medication, and that medication, which is designed to slow intestinal movement, is the single worst thing you can introduce into this situation. It does not address the blockage. It slows the surrounding bowel activity, reduces what little pressure might help dislodge the mass, and allows the impaction to continue hardening. If you have liquid discharge alongside a persistent feeling of rectal heaviness or fullness, please do not take anything designed to stop diarrhea. You do not have diarrhea, you have a blockage with overflow. Now let's talk about your bladder, because this one surprises almost every patient I have ever discussed it with. You may find yourself suddenly struggling to urinate. You feel the urge, you go to the bathroom, and either nothing comes out or only a painful, interrupted trickle. You might need to go every 15 minutes but produce almost nothing each time. And you likely assume this is a urinary tract issue, a kidney problem, or in men, a prostate flare. But here is the anatomical reality. Your rectum and your bladder occupy the same narrow, confined pelvic space. They are immediate neighbors with very little room between them. When your rectum becomes severely distended with a hardened impaction, it expands into that shared space and physically compresses the bladder from behind. In women, it can also press against the urethra directly. The result is partial or complete urinary obstruction that has nothing to do with your urinary system and everything to do with what is happening 1 inch away in your bowel. Pattern interrupt. I want you to stop for just a moment and think about whether you have ever had urinary symptoms and bowel symptoms at the same time and treated them as two completely separate problems. Because in many cases, they are one problem with two faces. The third symptom is lower back pain, and this one is dismissed constantly, especially in older adults who already live with some degree of back discomfort from arthritis, disc issues, or muscle strain. The pain from a significant rectal impaction radiates outward in a way that feels deep, dull, and nonspecific. It spreads into the lumbar spine, down through the buttocks, sometimes into the upper thighs. It does not feel like a bowel problem. It feels like your back went out. If you are experiencing unexplained worsening of lower back pain in combination with any change in bowel habits, those two things together are a signal worth taking seriously, regardless of your history of back problems. And then there is the fourth symptom, the one that most people find the most surprising: sudden cognitive changes in older adults, mild confusion, disorientation, unusual agitation, or mood shifts that appear without an obvious trigger. This is not imaginary, and it is not rare. Significant physical distress, especially involving abdominal pressure and systemic discomfort, can produce neurological symptoms in older adults, particularly those who are already managing any degree of cognitive vulnerability. If an elderly parent, spouse, or loved one seems suddenly mentally off and you cannot identify a clear reason, their bowel status deserves serious consideration. These four symptoms, the overflow discharge, the urinary retention, the radiating back pain, and the cognitive changes, are your body using every available channel to communicate that something is wrong. Learning to read that communication accurately is not a small thing. It may be one of the most important skills you develop for protecting your health in the years ahead. I want to shift the tone here for a few minutes, not to alarm you, but because I respect you enough to be completely direct about what is at stake if this condition is left unaddressed. You deserve to have this information delivered clearly, without it being softened into something that doesn't carry its actual weight. A fecal impaction is not a nuisance condition. It is not something that will reliably resolve on its own if you give it enough time. It is a genuine medical emergency in the making, and it follows a progression that is well documented, well understood, and entirely preventable if you act before it advances. Let me walk you through what that progression actually looks like inside the body, because most people have no idea how quickly things can escalate. In the earliest stage, the intestinal wall surrounding the impacted area begins to experience sustained abnormal pressure. The bowel wall is living muscular tissue. It has a blood supply, nerve endings, and a functional capacity that can be exceeded. As that pressure builds over hours and days, blood flow to the stretched tissue begins to diminish. The muscle fibers, starved of adequate circulation, lose their ability to contract effectively. The section of bowel surrounding the impaction begins to go quiet. Clinically, we call this an ileus, a functional shutdown of intestinal movement. And once that happens, the digestive system above it begins to back up. At this stage, nausea arrives, then vomiting. The abdomen begins to visibly distend. The person stops passing gas entirely. They feel genuinely systemically ill, not just uncomfortable. This is no longer a digestive inconvenience. This is a body in distress. Now here is where I need your full attention, because stage 3 of this progression is the one that changes everything. The intestinal wall has absolute physical limits. It can stretch only so far before the tissue fails. When the pressure inside an obstructed segment of bowel exceeds what the wall can withstand, that wall tears. And when it tears, the entire contents of the bowel, the fecal material, the bacteria, the toxic byproducts that your digestive system was working to eliminate, spill directly into the abdominal cavity, into a space that is completely sterile under normal circumstances. What follows is peritonitis, a rapidly spreading bacterial infection of the abdominal lining that without immediate surgical intervention is fatal. I am telling you this not to frighten you into paralysis, but to give you the correct framework for understanding why the timeline matters. The window between a serious but very manageable situation and a life-threatening emergency is narrower than most people assume. And the difference between those two outcomes often comes down to whether someone acted early enough. So what does the danger zone look like from the outside? What are the signals that mean you stop whatever you are doing and call 911 or drive directly to an emergency room? A rigid abdomen, one that feels board-like and is tender when you press on it, is a red flag. Your abdomen should not feel like a hard surface. When it does, something inside is under critical pressure. A fever above 101 degrees Fahrenheit in combination with abdominal symptoms is a red flag. Fever means your body is fighting something. In this context, it may mean early infection or tissue involvement that requires immediate medical evaluation. Abdominal pain that is constant, severe, and worsening rather than coming in waves is a red flag. Cramping that comes and goes is uncomfortable but not immediately alarming. Pain that builds steadily without relief is a different clinical signal entirely. Complete inability to pass gas is a red flag. Gas is always being produced by your digestive system. When none of it can move, it means the blockage has become complete. Vomiting that does not stop, especially vomiting that begins to smell foul or appears dark, is a red flag. This indicates that the backup has reached a critical level and the digestive system is attempting to decompress itself in the only direction available. And finally, any combination of sudden dizziness, drop in blood pressure, cold and clammy skin, and confusion is a red flag that requires an immediate 911 call. This profile suggests early septic shock, and it demands emergency response without delay. These are not wait-and-see symptoms. These are not symptoms you monitor overnight and reassess in the morning. These are go-now symptoms. And recognizing them correctly may be the most important clinical distinction you ever make for yourself or for someone you love. If you are still here with me and finding this valuable, type the number 3 in the comments right now. It genuinely helps me know who is watching and how this content is landing. Now, I also want to say something that I believe is important to hear. If you are sitting with some of these symptoms right now and you feel frightened, that is appropriate. That fear is your body's intelligence working correctly. Use it to motivate action, not to freeze you in place. The information I just gave you is not meant to leave you feeling hopeless. It is meant to give you a clear, calibrated sense of urgency so you move in the right direction at the right speed. Because here is the other side of everything I just told you. For the overwhelming majority of people who catch this condition before those emergency symptoms appear, resolution is achievable, often at home, with the right protocol applied correctly. And that is exactly where we are going next. All right, we have covered the biology, the symptoms, and the stakes. Now we do the most important thing. We talk about what you actually do, starting tonight if necessary, and what you change going forward so this never becomes your reality again. I want to give you a sequence that is clear, logical, and actionable. Not vague suggestions, a real protocol with real instructions, the kind of conversation your doctor would have with you if they had 30 minutes instead of 12. The very first instruction, and I need you to take this seriously, is to stop straining, right now, completely. I understand the impulse. When something needs to come out and it won't, the natural instinct is to push harder. But with a hardened impaction, that instinct is working directly against you. Every time you bear down forcefully, you are compressing already dense material into a tighter mass, driving it further against the rectal wall and putting damaging pressure on blood vessels and delicate tissue that are already under significant stress. Straining has never once, in the entire history of medicine, successfully dislodged a hardened fecal impaction. So we are taking it completely off the table. Your first active intervention is adult glycerin suppositories, available at any pharmacy without a prescription. But here is the piece of information that most people do not have. For a meaningful impaction in an adult, one suppository is almost never enough. The appropriate protocol for a significant hardened blockage involves using 2 to 3 suppositories at the same time. A single suppository simply does not produce sufficient lubrication to penetrate and soften a large dehydrated mass. Here is exactly how to do this correctly. Lie down on your left side. This is not arbitrary. This specific position, which physicians call the left lateral decubitus position, uses your anatomy to your advantage. It aligns the lower colon and rectum in a way that allows the suppositories to travel toward the obstruction rather than falling away from it. It also removes gravitational pressure from the rectal area, which is already inflamed and sensitive. Before insertion, apply a generous amount of water-based lubricant to each suppository. The tissue inside your rectum is irritated. Dryness at this stage increases pain and makes the process more difficult than it needs to be. Insert all three suppositories gently, but with enough depth that they are positioned alongside or directly against the hardened mass, not near the entrance where they will simply slide out. Then lie completely still for a minimum of 30 minutes, ideally 45. This is the step that most people fail on because it requires patience in a moment when patience feels impossible. But glycerin works by melting slowly at body temperature, dispersing as a lubricating layer around the mass, and stimulating the rectal wall to increase its own natural secretions. That process cannot happen in 5 minutes. Give it the time it needs. After your waiting period, rise slowly and allow your body to respond without any pushing or forcing. If there is movement, that is excellent. If there is not, remain calm. Give your body a full hour of rest. Drink a large glass of warm water, take a gentle walk through your home, and repeat the entire process. Warm water helps relax intestinal muscle tone. Gentle walking stimulates the kind of low-level peristaltic activity that supports the process without aggravating inflamed tissue. The second round very frequently produces results when the first did not, because the first application softens the outer layer and the second reaches the interior. If 2 complete rounds produce no movement, or if you develop any of the emergency symptoms I described in the previous section, you go to urgent care or the emergency room. That is not a defeat. That is the medically correct next step. The clinical team has access to high-volume enemas delivered under controlled pressure, imaging tools to assess the extent of the blockage, and if necessary, the option of a procedure called manual disimpaction performed under sedation. It is a well-established, safe intervention. The relief patients describe afterward is immediate and significant. Now let's talk about protection going forward, because clearing the current problem without changing the underlying conditions simply means you are scheduling the next episode. Water is the non-negotiable foundation of everything. Your large intestine extracts moisture from waste as its primary function. If the incoming fluid supply is inadequate, stool hardens. It is that simple. The challenge for adults over 55 is that the thirst reflex diminishes with age. You can be meaningfully dehydrated without feeling thirsty. The practical solution is to stop relying on thirst as your guide, and instead drink on a schedule. 6 to 8 glasses daily, beginning with a full glass of room temperature water before you eat or drink anything else in the morning. That single morning glass activates the gastrocolic reflex, a natural wave of intestinal movement triggered by fluid entering an empty stomach, and it is one of the most reliable, medication-free tools available for establishing regular morning bowel function. Daily movement matters more than most people realize. Your intestines are muscular tissue. Physical movement of your body directly stimulates the contractions that move waste forward. A 20-minute walk after meals, even a slow and comfortable one, measurably accelerates intestinal transit. For those with mobility limitations, seated torso rotations, gentle leg lifts, or chair-based stretching provide meaningful stimulation. Have an honest conversation with your physician about your medications. Opioid pain relievers, certain blood pressure drugs, iron supplements, high-dose calcium, many antidepressants, diuretics, and antihistamines all slow intestinal motility. Your doctor may not raise this unless you do. Ask directly. Use a small step stool under your feet when you sit on the toilet. Raising your knees above hip level changes the angle of the rectal passage and relaxes a muscle called the puborectalis that otherwise creates a natural bend at the exit point. This one small change meaningfully reduces the effort required for complete evacuation. And establish a bathroom routine at the same time every morning and honor it daily, whether you feel urgent or not. Consistency trains your digestive system to synchronize. Within 1 to 3 weeks, it begins to initiate movement on schedule. Your digestive health is not a minor concern. It connects directly to your energy, your immune function, your sleep, and your quality of life. Take it as seriously as you take everything else. Before we finish, I want you to remember one thing more than anything else we discussed today. Severe constipation and fecal impaction are not simply uncomfortable problems that come with getting older. They are warning signs from the body that something is no longer working the way it should, and ignoring those signals can lead to pain, infection, hospitalization, and a rapid decline in overall health. The difficult part is that these problems rarely appear all at once. They build slowly, often hidden behind symptoms people dismiss every single day. If you notice constant pressure in the rectum, sudden leaking that looks like diarrhea, ongoing bloating, trouble urinating, loss of appetite, or exhaustion that seems unusual, do not brush it aside and hope it disappears. Your body is asking for attention, not silence. And please, never force or strain repeatedly for hours. That can make the situation far more dangerous than most people realize. What matters now is taking small, consistent actions before things reach an emergency point. Drink enough water even when you are not thirsty. Walk every day, even if it is only around your home. Pay attention to medications that may slow digestion. Create a regular bathroom routine and respond when your body gives you the urge to go. Most importantly, stop feeling embarrassed about discussing digestive health. Some of the most serious complications I have seen in older adults started with symptoms they were too uncomfortable to mention. There is nothing shameful about protecting your health. Thank you for spending this time with me today. If this video gave you clarity or reassurance, let me know in the comments. Share it with someone who may need this information, and subscribe for more honest conversations about senior health and aging well. Take care of yourself, listen to your body, and never ignore the quiet warning signs. The earlier you act, the easier these problems usually are to reverse, and that single decision could protect not only your comfort, but also your independence, confidence, and peace of mind in the years ahead too.